Thank you so much, Henry. Always great pleasure, great honor to be here with friends, with mentors, and for me, it's always amazing for me to look on my CV and in the middle there see that I was once part of Team Atlanta. Really something special. I believe I will always be a little bit, right? Good feeling. So we have 40 minutes to try to share with you the new updates on what we're doing with digital smile design. And the topic today, the focus will be what we call the smile frame. For us, the smile frame is the starting point of our facially driven and digitally designed interdisciplinary dental treatment. So let me try to explain what is the smile frame. The smile frame are a couple of simple drawings that we do over simple photography that will try to give us insights about what we need to do to develop this new project for the patient. Through the smile frame, we will understand the face better. We will integrate the specialties better. We will educate the patients better. We will be able to design all the devices that we need to perform this case, from surgical guides, aligners, restorations, splints, crown lengthening guides, prep guides, everything. Through the smile frame, we will bring digital dentistry to our daily work, and we will do what is also very important, what we call the quality control procedures in between every one of the steps. This is only possible through technology, and it's beautiful to see how nowadays technology is really ready to help us on a very realistic way. And it's not about saying analog versus digital, but it's analog plus digital. The thinking process is still the same. Performing high-end dentistry is still exactly the same. We still need the knowledge, the hand skills, decision-making process, treatment planning, experience, and all these information and skills that we need to be a good dentist. Now, with digital dentistry, we can go even further and become more predictable and deliver better cases with less stress. So the facially driven treatment plan philosophy is just translated into the digital world through the smile design concept. Interdisciplinary dentistry becomes more realistic because we have protocols, digital protocols for communication. Integrating aesthetics and function becomes reality as well because everything is easier when we see everything in 3D in front of us. And we can make better decisions because we can see better. As I mentioned, the principles are the same. Our mentors and our masters, they showed us the path for facially driven interdisciplinary treatment planning. What we are doing is just bringing these concepts into the digital world. So for us, it's beautiful to have this, but the digital world will help people to do better, but will not save the ones that are still not doing good dentistry. So doing good high-end dentistry with our own hands and brain is still the key factor. Now, once we have that, we need to embrace this new world, accept the paradigm shift, and understand that we cannot stop evolution. And it's not the future anymore, it's the present. When we shift from regular high-quality dentistry to modern high-quality dentistry, we understand that it's not about the procedure anymore because we already control them, but it's about how we link procedures. That's what I believe is the future or is the modern challenge of dentistry. It's not about having a good technician that does a beautiful wax-up and a good dentist that does a beautiful prep. It's how do we link the wax-up to the prep? That's the new challenge. Every single step needs to make sense with the step before and with the step that will come after. And this is another new challenge. So when we get to the end, we can see a case that went through orthodontics, perio, and now it's going to receive veneers, and we see that the teeth and gum are exactly in position so we can deliver minimally invasive, high-quality dentistry. So integrating everything is the challenge. Communicating this vision is the challenge. What we see is that most of the mistakes that we do are not related to lack of skills, of technical clinical skills, but are usually related to lack of communication and lack of vision at the right moment. So we know that the old devices that we were using are not good enough to give us this facial visualization and the integration between the working model and the patient's face. It doesn't matter if we work digital or analog, the challenge is the same. Technicians all over the world, they are looking at a model and feeling like they're lost in space, not understanding the realistic relationship between what they're doing and the lip dynamics and the facial aesthetics. So it's beautiful to see how nowadays we can do this in the computer instead of really struggling through analog devices, but being able to integrate digital models with CBCTs, with cephalometric analysis, with tomography, with facial images to understand what we need to do to develop this project. So nowadays, we don't do wax-ups anymore, we do digital wax-ups. And you can see the advantages of doing this on the computer, how you can always be related to the face, how you can see the integration between the upper arch with the lips and the face. And then even go further and see the relationship between your wax-up and the bone, your wax-up and the soft tissues. So you can see that not only from the frontal perspective, but now we are working a lot from the sagittal view. Is the key factor for us to become an even better smile designer, learning from orthodontists and orthodontic surgeons how to understand the 3D position of the central with the face. There's no reason why we shouldn't use these concepts to do initial aesthetic diagnostic wax-ups. So instead of guessing, we will analyze these cases on the computer and bring this information, so we will do cephalometric lines over wax-ups, and the wax-up will be calibrated over this, even if the case is not going to go through ortho or orthognathic. This is what we call the cephalometric guided wax-up or the orthognathic wax-up. It's the same principle. So you can see that one side we are guessing on a model, the other side we are controlling absolutely everything and bringing this beautiful knowledge into our process. Bite registration is another thing. We can scan these bites, and instead of having to struggle through the process of registering, mounting, and bringing distortion, we can just have this bite automatically inside our computer and work with this new position or this new vertical dimension. It's also very nice to see that now in the software we can actually record the movements with simple devices in the mouth and not with complex things, and understand the envelope of function and understand what is the most comfortable position for this jaw. And even better, understand how our new restorations will interfere with this movement. So we can detect exactly the interferences and how we need to change the design to have a more comfortable bite, a more comfortable maxillomandibular relationship. We can even re-establish this vertical on the computer, design devices that can go to the mouth and test drive this new position that we think it's comfortable, either with a night guard, a bite registration night guard, or even doing what we call bonded night guards. That is actually transitional additional restorations that will translate this new vertical dimension to the mouth. So when it comes to determine the vertical dimension, we can go back to the computer and really find, on utilizing these devices, the most comfortable position for the jaw, for the articulation, and for the muscles, and have a very precise guess of where we want to be. When we have this on the computer, we can design these restorations instead of designing a night guard, and we can print these models and spot etch the patient's mouth and bond immediately these restorations. So in one shot, we are rehabilitating the patient completely with the new vertical, the new function, the new design, the new facial integration, everything in one shot. And the beautiful thing is that is minimally invasive or non-invasive at all. We are additively test driving this new situation and transforming a complex case into a very simple situation, where now, after the patient is comfortable, we can then start changing these transitional restorations into extractions, implants, or final restorations if needed. So this is the patient after one session, coming in with his old bite and leaving with the new bite, new aesthetics, everything done in one shot. So when it comes to the diagnostic wax-up, instead of also guessing this new incisal edge position, what we can do is bring the video into the software and analyze lip dynamics and make a better guess about where do we want this green line to be. And then we can start the wax-up, positioning the central incisors, doing the full buckle of the upper arch, and instead of having to guessing on the analog world and hoping we could have the face on the digital world, we do have the face always by our side, and we can always test drive this and fine-tune this design. So we can see that on the left side, on the analog world, we have limitations that are coming from the hand of the technician, because it's very difficult to wax, to do diagnostic wax-ups. So we have problems with midline shift, inclinations, normal, regular problems that we always have. And on the right side, we have the perfect integration with natural morphology, since we always use library of teeth that comes from nature. So we can scan natural teeth and do diagnostic wax-ups that are completely looking natural. So there's no reason anymore to struggle through the process of trying to reproduce nature with our own hands when it comes to shape and texture. We can just scan nature. We can wax up a case of a mother with the beautiful dentition of the daughter, for example. We can scan somebody today and rehabilitate them in 20 years with the same exact shape and texture that they used to love when they had a beautiful smile. The other great advantage, training somebody to do a very beautiful wax-up takes an average 10 years. Training somebody to design these things on a computer, less than 10 months. So we can see the advantages. Another advantage, whenever you're done with this initial project, you can overlap this into the rest of the software, where you can plan ortho, perio, crown lengthening implants, restorations, orthognathic surgery, everything based on the same project. So getting closer to nature, bringing nature into the software. We can then wax up the lowers and integrate the lowers towards the upper. Starting from the uppers, we determine the vertical dimension, the space that we need, and then we can start creating the intercuspation, the occlusal scheme that we want. Now, again, another advantage. We can rotate the model, and we can see the overbite, overjet. Even better, we can zoom in from the sagittal view and calibrate the angle of anterior guidance, fine-tune the millimeters that we want for overbite and overjet, and then understand what kind of treatment that we need to do to make this possible. If the diagnostic wax-up, virtual wax-up, is not realistic, we can move things around, or we can start analyzing or getting to the conclusion that maybe we need orthodontics, or even doing an orthognathic procedure. So everything becomes much clearer. So what we want is to utilize softwares not only to design devices after we already made decisions, but to utilize the software to help us to make the best decisions. Because when we have new patients coming in, we don't know if we're going to do implants, yes or no, or orthodontics, or perio, or crown lengthening. After we know the treatment plan, it's very easy to go into the software and ask the software to do this device or that device. And this is a waste of technology. This technology is here to actually help us visualize better and make the decisions before we even start performing the clinical procedures. So after we have the design, of course, on the conventional world, we would have a wax-up that we can scan. Nowadays, this doesn't exist anymore. We start from digital directly, and we can then transform this initial wax-up, overlap into preps, restorations, and mill whatever kind of material that we want. Usually on big rehabilitations, what we do is what I call the prepless, adhesive, non-invasive, CAD/CAM composite restorations. Everything is bonded. Everything is additive. So we can test drive this and really feel comfortable before we start prepping teeth. So this is what we actually want. As a technician, was always a dream for me, how to be predictable from an initial situation all the way to the final. Almost impossible to do this with the analog world. Nowadays, the initial project is kept, and we can almost guarantee that we're going to have the initial project identical to the mock-up, identical to the provisional, that is identical to the final. Even better, without having to wax, to layer, to press, or to cast. Very difficult procedures that we are removing away from us in most of the cases by achieving these kind of results with monolithic CAD/CAM design restorations. Everything starts from the smile frame. What is the smile frame? Very simple. A couple of drawings. Actually, we need to make 8 decisions. So we broke down the smile design process into 8 decisions that we have to make, basically facially driven, even better, driven by the dynamics of the face. So everything comes from motion, everything comes from the movement. So we start from simple videos, smartphone videos, where we're gonna look into this video and make the decisions. We will also make photos out of these videos, and that's why we don't do dental photography anymore, unless we have time and we want to do it for a hobby, as a hobby, for lectures or publications. We don't need to do dental photography anymore. What we do is snapshots of a video. Every second of a video gives you average 30 photos. An iPhone gives you a camera, a 4K high-definition camera that allows you to pause this at any moment and make amazing images, hundreds, thousands of pictures, saving a lot of time and eliminating the process of struggling to complex photo documentation. We make facials, we make profile, 12 o'clock, occlusal, intraoral videos, interviews, functional videos, phonetic videos, structural videos, everything in 5-7 minutes with the phone. It's done, and you have all the information that you need to develop beautiful high-end procedures for your patients. So you start from the initial video, facial analysis, snapshots, smile frame. From the smile frame, you can do a conventional wax-up, but nowadays what we do, we go back to the software, develop a 3D project that is a copy of the smile frame, print that model, go to the mouth, and you can test drive the mock-up in the patient's mouth immediately. Very precise, very predictable, immediate facial integration. Printed technology is growing very fast, and we know that that's the future. We should definitely think about that. We think that before we even think as a dentist to buy a CAD/CAM chairside system, we should be thinking about buying a printing machine. Much more sense to have a printing machine in your clinic than to have a CAD/CAM system. With the printing machine, you can print your mock-ups, print your models, and create all the devices that you need to rehabilitate the patient, as surgical guides as well. So on our workflow, we start with the 2D smile frame, very simple, very fast, and then we jump into the 3D softwares, and then after that, we can overlap into the interdisciplinary platform. Pieces of the software that will cover everything that is possible to do in dentistry, everything in one software, everything in one platform. So we can really utilize the software to think the process before we make major decisions. So this is the only way that we believe softwares can become an interdisciplinary tool, really following a facially driven philosophy, helping us to visualize, treatment plan, and smile design the cases. Going back to the smile frame. How do we develop the smile frame, since this is the entrance for everything? We start looking at the video and we have to make 8 decisions. Where do you want the midline to be? Smile curve to be? Interdental proportion? Intradental proportion? Gingival curve? Papilla curve? And then we can analyze where we are, where we want to be according to the frame. We move into 12 o'clock, the volumes, the vermilion of the lower lip, where we are and where we believe we should be, where the face is asking the teeth and gum to be. Occlusal, 8th decision. Occlusal arch, space distribution, and then analyze where we are and where we want to be. So what we usually do is we develop the smile frame, and when we are communicating with the team of specialists, instead of sending just conventional documentation, we send panoramic x-rays, models, pictures, medical history, perio chart, whatever you all send and discuss, plus this slide with the video and the smile frame, so everybody's on the same page. So the smile frame will help us with the brainstorm, the interdisciplinary brainstorm, communication with the specialists, treatment plan presentation to the patient, create a 3D mock-up that is immediately in harmony with the face, and integrate this with 3D softwares to move forward with the actual treatment. These parameters are not new. Everything that we use, all the knowledge that we use to develop a smile frame comes from dentures. That's why we usually believe that dentists and technicians that are good with dentures are usually the best smile designers. They understand the principle that we need to start outside in. We need to look at the face, because on their case, there's nothing in the mouth to look. But for us, it doesn't matter if the patient has all the teeth in the mouth. We will always start from the principles of dentures and erase the patient's teeth for a second and allow us to develop a facially driven smile, bring the teeth and gum back into the game, and analyze the discrepancies between where the face is asking things to be and where teeth and gum are right now, and try to develop a treatment plan to minimize this discrepancies. So the smile frame will also be the key for us to divide the case in this classification that for us is super easy and important. According to the smile frame, we will have 6 types of cases. Cases that teeth and gum are pretty much on the right position, we just need to restore. Cases where we need to change the gum position and then restore. Change the vertical, the bite, and then restore. Place some implants, prepare the tissue, and then restore. Move teeth around and then restore, or move the whole arch and then restore. Very simple to classify when the smile frame is in front of us. So we can really create specific workflows for each type of case. What is the key here? The key is that we don't want to restore complicated cases. Our ideal goal is to only restore easy cases, type 1 cases. So every case that is not type 1, we want to first transform it into type 1, bring tissues and teeth into the frame, and then it becomes much easier for us just to prep and bond. So it's very simple to go through this flow and understand and discuss with the team what needs to be done, what is possible, what is reasonable, how close we can get to the smile frame, the facially guided smile frame, and then move the patient into this process and explaining this to the patient until we have a situation close to type 1 that we can then just finalize our preps and cement the final restorations. So type 1 cases, the easy ones, they can be additive or subtractive. If we have teeth sticking out the frame or the teeth are inside the frame. So if the case is additive, the most simple one is very simple. Everything is inside. This is the case that everybody loves. We don't need to change the bite. We don't need to change the gum. And we don't need to move the teeth. So we just need to restore them. So if we have this kind of situation, we do the 2D frame, 3D design. The digital wax-up will be made with natural morphology, prepping through the markup, scan the preps, overlap these images, and make final restorations identical to the markups and identical to the provisionals. So at this point, we can again go into the series of amazing blocks, amazing materials that the companies are developing for us, and just pick the one that we think is appropriate for that case and mill them, monolithic, full contour. That is what we believe is the future. Monolithic, full contour restorations. It doesn't matter the material that we want to choose materials that are monolithic. And this is the type of quality that we can already achieve with monolithic restorations. We have beautiful multicolored blocks with translucency and chroma, and we can really bring this concept into the fact that we are utilizing natural shapes and natural morphologies and have these restorations done in a very, very simple way. That means that scanners, softwares, and milling machines are ready for us to produce this kind of restoration and eliminate very stressful procedures of our daily work. What happens when we have a subtracted case? We have to reduce. So then, what we need to do, we need to go through the digital workflow and develop a strategy to help the dentist not to lose the references. The first project is the ideal project, showing that the teeth underneath are sticking out. We save that project. We duplicate that project, and we bring the teeth out now to make an adapted additive wax-up to allow us to make a motivational markup. Then we move the teeth back to the ideal position, and now digitally we're going to trim the pink areas. We're going to trim digitally the teeth and have the ideal project now done based on the white design. So with these 3 projects, what we're going to do is we're going to print 3 models and send 3 guides to the doctor. So he can go through the process of motivating, pre-prep, through the markup, and then have the final restorations done. So this is the sequence. First project on the top, ideal with the teeth sticking out. Second, it's adapted, bring out, make it bigger so we can do a motivational mock-up. Third, we move back again and we trim the blue. 3 printed models, 3 guides. Second guide goes first. We put it in the mouth. Motivation. The patient says, wow, I love it, I want to do it. Okay, the case is approved. We move back into guide number 1. This is a guide with windows, so every blue area comes with a little window where we're going to prep only the window areas to reduce just enough so the third guide, the ideal guide, can come in. So when the ideal guide can come in, that means the ideal project can come in. So then we do a second mock-up, is the ideal design. Why do we do a second mock-up, the technical mock-up? Because we don't prep teeth, we prep mock-ups. We want to prep through the mock-ups exactly the clearance that we need for the final restorations. Type number 2, crown lengthening case. So we do the frame, we detect the need for crown lengthening, so we can do the planning, do the surgery, and make the veneers or crowns at the end. So let's go through one full case here. Crown lengthening is needed. The smile frame is telling us that. We do the initial project, ideal wax up, and then we divide this in 2 projects. One project will go over the gum, motivational, simulation over the gum. The other project, we will trim the gum and move teeth back to the ideal submergence profile, to the root surface. So now we have these 2 projects saved that we can then transform it into 2 models. So we see we are trimming the gum, bringing the teeth back. So we now have the second project, ideal, realistic project done. 2 printed models, 2 guides. 1 over the gum, 1 realistically following the root surface. So what we do, continue, bring this project into the surgical part of the software. Now we're going to plan the implants and design the abutments and restorations according to this wax-up. Since it's one software, we can go back and forth. Surgical part, facially driven smile design part. So we design the abutments, slightly subgingival, everything is milled, everything is printed, and we send to the doctor. So now the doctor has everything he needs to do everything in one appointment, and that's the other advantage of the digital workflow, shrinking the treatment, doing more things in one appointment. First mock-up, motivational mock-up. The patient, we do this before the patient even accepts the treatment. So we place it in, we record, we show to the patient loves it, she accepts, she wants to do it. So okay, so what we do is now we remove this motivational mock-up and we can go and start with the crown lengthening guide. The crown lengthening guide that we do for the dentist has a window. It's slightly different. It's more simple, less errors. So what we do with this, we can guide the instrument and even guide the zenith position with more precision, a copy of the smile design project that we developed digitally. So this is very easy to do over a printed model. This guide has another feature, not only the window for the gum, but 3 millimeters above that, the bone reduction part is there. So it's a double guide. So if we need to open the flap, the bone is there, we cut the bone to the top of the guide, and we shape the tissue to the window area. So detail after detail to reduce the chairside time, create precision, and make this initial project more similar to the final result that we want. So on this case, the surgeon decided to use electrosurge, crown lengthening, gingivoplasty, no bone reduction on this specific case was needed. So we could move in, or the surgeon could move into this extraction, implant placement, with fully guided situation where we always immediately design the final abutments and the crowns ready. So everything is pre-made if we go fully guided, and we usually only do that on single unit cases. So we have here fine-tuning the tissue, minimally invasive preps, spot etch, and the provisional immediately after the surgery. Everything in one appointment. What is the highlight here? 2 models, 2 moments. What is the cool thing here? We didn't have to adjust the buckle of the provisionals after surgery because they were already tilted back, following the root submergence profile. Everything was exactly where it should be, so we saved a lot of time not having to shape this in the mouth. Vertical augmentation, worn dentition cases, what do we do? Facially driven, smile frame, bite registration, go to the software, fine-tune the vertical dimension, design your wax-up, integrate with the restorations, tabletops on the back, palatal veneers on the uppers, and buccal veneers if needed. Everything is designed exactly the way we believe it should to allow us to do prepless bonding, completely prepless bonding. So we don't have problems with path of insertion. It's just additive. Everything is milled, everything is bonded, and you can rehabilitate the patient in one shot. And test drive the comfort, test drive the occlusion, test drive the aesthetics without having to compromise the situation or lose the old relationship. If we need implants, the smile frame is there. We can do the 2D, 3D design and then plan the implants accordingly and then also design the final restorations according to the 3 views. Mill everything in advance, so when we go to the clinic, everything is done in one shot. We can then translate this design into the final outcome of the case. One shot, one appointment, the patient comes in and has the final prosthesis. Not the final prosthesis, the transitional prosthesis, but the file is there. We can always duplicate this with the final material. If we do the frame, orthodontics is necessary. What do? This is what we do. Utilizing this lady as an example. Extraction is needed. Doctor wants to do some ortho improvements before extraction. What do? Facial analysis, smile frame in 2D, scan the models, go to the software, and then the software always links 2D into 3D. So we don't move teeth lost in space. We always have the face as our guide. As we move the teeth, we can see the drawings that were facially driven, so we know exactly where we are going. We can calibrate these from the frontal view and from the occlusal view, so we know exactly the impact of what we are doing on the combination ortho-restorative. So it's a restoratively driven orthodontic procedure that will combine occlusion and aesthetics. Always having the face, you can always test these movements and check with the face what happens. Even better, what we are doing now is not only doing 2D drawings, we are doing the final 3D wax-up that will do the final shape of the teeth after ortho, but before ortho. So we ignore the position of the teeth and we do a 3D wax-up that is purely facially guided. And then we overlap this to the orthodontic part of the software and we move teeth into the future restoration. So it's beautiful to see how you can plan orthodontics, and on this case, for example, moving centrals inside, forward, to bring this situation to the ideal final outcome of the blue line. So you can really be minimally invasive, really do orthodontics, preparing for minimally invasive restoration. So we see the whole workflow. Initial situation, scan, smile frame, 3D wax-up, move the teeth into the wax-up, share with your orthodontist, analyze if these movements are possible and how to make that happen, and then create the printing, create the aligners, go to the mouth, and move the teeth. Let's make it a little bit more complicated. Let's bring orthognathic into the game. So now we have perio, implants, restorative, ortho, and orthognathic in one patient. And the doctor wants to do everything in one appointment. So how can we do that? With digital technology, it's possible. This is not something crazy. We are doing this a lot in Brazil. This is what we call a day clinic situation. The patient goes in the morning to the hospital, general anesthesia, 6-7 hours in the chair, many specialists coming in and out, and everything is done in one shot. Everything starts from the facial analysis smile frame. So we are playing with the images, and what we want is to do a Le4 maxilla shifting and segmentation posterior impaction, and then place the implants, soft tissue fine-tuning, restorations for this patient. So we are designing the case, communicating with the drawings, making final decisions, utilizing these drawings to also communicate to the patient, get the patient on board, and then we can beautifully utilize the integration of the software to plan absolutely everything we need. So as you see here on the first window, what we have is the smile design part of the software, where we will integrate 2D into 3D and design the smile according to the face. Then we will jump into the orthognathic part of the software that will allow us to understand the jaw movement, the maxilla movement, first the impaction of the posterior area, then the shifting of the whole arch, and then you can bring the same wax up. As you bring the wax up, you can wax the lowers, and as you wax the lowers, you start to see exactly the integration with the new position of the uppers, with the new position of the lowers. You can check with the face as well and see how the future wax-up will look before the shift and after the shift. When you're happy with this, you can then finalize with the surgical part of the software, where now you know where the lowers should be, so you can bring the wax up of the lowers and plan the implants according to that. Even better, now that everything is done in 3D on the computer, the first part of the software will generate the models and the restorations. The second part of the software will generate the surgical guides, implant provisionals, and positioning trays. And the third part will generate surgical models, splints, for the orthodontic surgery. So everything goes into a box, everything goes to the doctor, and the whole team goes to the hospital to make it happen. So they were able to take just few photos, and I can understand why. It's crazy, very busy. The anesthesiologist is always counting on the clock how many minutes to stop everything. So they have to speed up. Extraction, implant placement, pick up the implants, lift 4, segmentation, splint, maxilla fixation, bonding the restorations, everything in one shot. So we can see here after everything was done, and we can even see a short video here done recently to show the before and the final smile with the restorations completely computer designed. So to finish, I have 4 minutes to finish. I will try to show a little bit more on complex implants restorative, not complex, but implant restorative cases. I'm going to move very fast because it's always the same principle. Dynamic facial analysis, 2D smile frame. The 2D project is overlapped into 3D. Do the digital 3D wax up. Then you have the final guided 3D project done. First thing that we do, export, print, tray, motivation. Patient comes back to listen to the treatment plan. Before we tell them the plan, we're going to put the mock-up in, make nice pictures, present them the project, sit down with them, explain the treatment. Hopefully they accept the treatment, and we can then move forward. So the patient accepted everything. First step here, the doctor prepped through the mock-up, scanned the prep, sent us back the information. We're going to translate wax up into restoration, identical shape, identical texture, identical vertical dimension, and occlusal scheme. So the restorations are milled. I'm going to finish, polish them, and then we're going to move into the surgical planning, leave the restorations aside. We're going to then bring the 3D wax up into the surgical part of the software, analyze the situation and relationship with the bone. One side is going to be fully guided single unit. The other side we're going to have sinus lift, 2 implants, and we're going to pick up a provisional, screw retained provisional. So abutments are designed. We can fine-tune the abutment design with the final restoration that is related to the full wax-up, related to the face. And then we can go and mill, print everything in advance, and send back everything to the doctor. So what happens? Remove the provisionals, place the first guide. Surgery is done, fully guided on the right side. That means final abutment and crowns are pre-made. On the left side, sinus lift, 2 implants are placed, and we have now a pickup provisional with the pickup tray. So every time we have a pickup, we always have a tray that translates the 3D design into the mouth. Nothing is loose, nothing is lost. So we're going to put the tray in, pick up the implants, unscrew, and finish outside the mouth. So bite is kept in the same position, contact points, almost no adjustments, everything is in position, and in 3 times less time than usual, we have the full mouth rehabilitation done in 1 session. And here's the patient coming out of the surgery, and I'm filming him, showing him the picture exactly after the moment that he was treating the patient. This case was done with Dr. Miguel Stanley in Lisboa, Portugal. Okay. 1.5 minutes. Denture case. Denture case is interesting. What we do, the same. We pretend the denture are teeth. So we do the facially driven plan, smile frame, 2D. 2D become 3D. We do a wax up over the old denture. We analyze the discrepancies. And then if the dentist wants a trial smile, a motivational mock-up, we can then, after we adjust the position with the face, everything is looking good, beautiful natural morphology, we can then print or mill this denture, because this project was done with the integration between the STL file and the CBCT and the scan of the denture. Everything is placed together, so we can just mill a denture, put some pink over it, send to the doctor, and the doctor can do this trial smile that is identical to the project that we have on the computer. If the patient approves this new design, we go back to the computer, and then we can beautifully design the implant strategy behind this new smile. So we can overlap the pictures, the 3D CBCT, the STL files, everything, bring the cephalometric information and design the guides that we want to make this situation happen. It's really very nice to see that everything in 3D. We design the abutments, if necessary, surgical guides, and the immediate prosthesis, all with these anchor pins, so we don't lose the vertical, we don't lose the facial relationship. Everything is done, everything is milled, everything is printed, goes to the doctor, and in one appointment, you can go all the way to the immediate prosthesis with the very nice facial integration. We have 47 seconds, and I have the last case. Brazilians are usually very late, but I'm gonna be there. Just give me 1 minute. We start from the facial, iPhone video, CBCT, STL scan. Information is shared online, the team is planning online, maybe option 1, maybe option 2, finally decided option 3, full extraction, immediate loading. I start with the 2D design, facially driven, smile frame. So from the video, we create this initial design. This initial design will go back into the software and will be transformed into 3D. So the STL file is calibrated to the image so you can see the frame over the 3D model. So you can really develop the 3D wax-up completely guided by the frame approved by the doctor. So we bring again all those principles from orthognathic and cephalometric to calibrate, so the wax-up is calibrated to the cephalometric analysis. Beautiful information that every technician should use to design their wax-ups. It doesn't matter if the case is huge or more simple. Virtual occlusion, very nice as well to do that on the computer. Intercuspation is ready, and then we can jump into the surgical part and start to position the implants according to this new design that we want. If the doctor wants, motivation. We print the project, and the doctor can then try this in before even extraction, before even selling the case. The patient can see themselves with this new design and help the patient to accept the treatment or even be more confident into the surgical procedure. So here is the patient with the new mock-up, enjoying his new smile. The patient approves everything, it's super excited, so we can go in now and explain the treatment plan to the patient in 3D. Patient accepts the treatment, so we can then go for the surgery. So when the patient comes back, everything is pre-made. First guide, over the teeth, if the patient still has teeth. Drilling the anchor pins, that's all. Remove this guide is not going to be used anymore. Full extraction, upper and lower full extraction. Then we come in with the bone reduction guide, if necessary, trim the bone for a better interface, and then we can come with the second guide where we can go through with the implant placement. Fully guided or partially guided, it's an option of the surgeon. We usually do just initial drilling, partially guided on bigger cases. Implants are in, abutments are in, provisional abutments are in, and now a nice trick, instead of a denture that is lost in space, what we're going to do to avoid this kind of very tricky moment where we don't have the relationship of the bite and facial integration, instead of sending a provisional like this, we're going to send a provisional that has the same pins. So the provisional is milled like this. We can place the pink before or after, it doesn't matter. So we can capture the implants on the same exact vertical dimension and facial position that we designed it on the computer. So it's a very predictable way to keep the project safe. So we pick up the implants, we cut the pins out, we finish outside the mouth, we go back into the mouth, and we have this kind of integration with very little occlusal adjustment with exactly the vertical dimension that we defined before. A little bit of occlusal adjustments, we can add some pink if necessary, and then finally test the aesthetics, checking how nice the immediate aesthetic, facial aesthetic is. Remembering, this was all done in one appointment, everything pre-made, and you have to believe me on this. This is the provisional immediate after the surgery with no intraoral adjustments. The aesthetics was already there, midline was there, smile curve was there, lower curve was there, buccal corridor, proportions of teeth, everything that was done on the first smile frame project kept into 3D, and then from that moment on, all the way to the prosthesis right after surgery. So it's extremely exciting to see that this is reality, and this is what we are doing every single day. And I just want to finish with one summary of the whole process. It doesn't matter if it's digital or analog. We can divide the process of planning a case into 4 steps. First step is to look at the face and try to define the buccal of the uppers, ideally guided by the face, and then analyze the discrepancy between where this ideal position is and where teeth and gum are right now, and try to understand if there is a reasonable treatment behind this transition. Step number 2, find the comfortable position of the TMJ and muscles so you can bring the lower jaw into the game. It's not occlusion yet, it's just the position of the jaw. After you have this position, you can fine-tune the vertical dimension for functional or restorative convenience, and then determine the space that you want to be able to develop the restorations on the upper and lower large, so you can then jump into step number 4, and that means intercuspation. Actually developing those principles that we all know about occlusion to have a long-term stability, protect the teeth, protect the restorations, and have a happy patient. So to finalize, I can say that evolution is beautiful. Thank God. Can you imagine Maurice doing surgery there? We cannot stop this process, but basics is still there. Dentists, they still need to be great dentists, so they can take advantage of this beautiful technology. Technology is ready. The question now is to see if we are ready. I want to thank my family, thank my American family, Maurice, Henry, David, and Ronald. Thank you very much.